Respected chairpersons and learned audience, good afternoon, assalamu alaikum. It's been a great pleasure to be invited to speak at the conference organized by IPDI. But the topic that was offered to me initially appeared very interesting. But when I started preparing, I found that in a conference dominated by cardiologists, speaking on such a topic would be difficult. However, there would be some conflict of interest, and there is lack of authentic statistics on this matter. There is some scientific ambiguity of different studies conducted on this topic with no consensus, and already there is a war in Ukraine. I don't want another war here. Before starting, let me remind us that in the childhood, you used to play cricket, and there was never be an LBW out because the umpire used to be one of the batsman's side, and he would never let you go leg before wicket. So in any situation, when the judge himself is a player, the judgment will be jeopardized, and this is the case here. Anybody can identify these two persons? Okay, we'll talk about them later. Let's recapitulate a little bit of history of CABG and PCI. The first CABG was performed by Robert Goetz in New York back in 1960. It's a long way ago. And the Soviet surgeon, Valery Kolesov, he performed a few cases behind the Iron Curtain, which we didn't know until later. And René Fabolaro introduced the reverse saphenous venous techniques in the late 60s. And in contrast, in 1929, Werner Forsman, who happened to be a surgeon, did the first cardiac catheterization, practicing on himself, being as a patient. The Andreas Grundge's first successful coronary angioplasty was done on 16 September 1977, and intracoronary shunt started being implanted since 1986. So the coronary intervention as a procedure is much younger than the cardiac surgery. In Bangladesh, we have some statistics regarding the number of cases. In 2019, total number of CABG was performed 6,512, and in the lower curve, we can see a gradual rise. PCI numbers are not so much recorded, but it is estimated between 12 and 15,000 annually. There is some fundamental difference between the mechanism of action of PCI and CABG. PCI actually directly relieves and discrete obstruction and increases arterial lumen, but little effect on preventing plaque progression and rupture in other disease segments. Whereas CABG improves blood flow and also protects distal myocardial beds from future ischemic insult caused by proximal plaque progression or rupture. There are several studies comparing CABG and PCI outcome. One interesting one is syntax, where you can see in the graphs that if the syntax score is high, then CABG is superior to PCI. If they are comparable, then the difference is CABG is still superior, but the difference doesn't become significant enough to be statistically significant. When we compare between CABG and medical treatment, one interesting study is STITCH. The problem is there are very few studies comparing CABG and medical treatment, excluding the coronary interventions. STITCH is one of such studies which has shown that CABG provided a significant survival benefit over medical treatment alone after 10 years. CABG was primarily there are few words about the studies we have mentioned, that CABG was primarily performed on the patients who are more severe coronary disease than the PCIs, for obvious reasons. You know, only the last patients will be sent for CABGs. And all the trials we have mentioned are performed mainly without previous PCI, because PCI per se may disturb the inherent vasomotor functions of the vessels, possibly adding adverse event in case of a future CABG. And most of the investigators of these studies are cardiologists, and industry has its interest in favor of PCI, and their ethical issues are not strong often. Another important issue is economic consideration. I published a paper with an assistant professor of economics from University of Dhaka 2 years ago, where we found that CABG in any public hospital is cheaper for the patient than even a single stent PCI. But when we move to big corporate hospitals, even in those hospitals, CABG is cheaper if the number of stents in 3 or more. So in Bangladesh, this is a very important factor because we have to consider about the economic conditions of the patients. And we know that a huge percentage of our poverty in Bangladesh is related to the catastrophic health event related to a major cardiac intervention of a family member. Here we can see the CABG plus 3 stent PCI comparison in corporate hospitals in Bangladesh and India. CABG is cheaper, whereas in USA and China, PCI is cheaper, up to 3 stents. If anybody interested, you can have a look at this publication. It was published in the Cardiovascular Journal in 2020. Now, there are certain advantages of CABG. First, CABG allows the surgeon to inspect the lesion directly. Number 2, it brings new supply from alternative sources. We know that about 250 ml coronary supply is there, but when we put a lima or some venous graft connecting the aorta, there are some additional supply which were not there. CABG doesn't interfere with the vessel physiology. Internal mammary grafts release nitric oxide, which are very good vasodilator and vasoprotective actions. CABG improves blood flow of the Geopardies myocardium, and CABG protects distal myocardial beds from proximal plaque progression or rupture. Well, of course, PCI has its advantages as well. Most important advantage is convenience. It is convenient for the patient, convenient for the relatives, it is convenient for the operator as well. It can be done quickly, very little hospital stay, user-friendly for the patient and the operator. But convenience may be counterproductive unless it is used cautiously. You have to explain the pros and cons of the different modalities offered, and only then you have to decide. It is often argued that patient opted for PCI, didn't want to go for CABG. But that can happen, but you have to counsel him properly, knowing the pros and cons of all the procedures available. Then there are some aggressive methods. We often find coronary angiograms which are not complete. I mean, whenever the operator decided that this is not a case of PCI, he may not opt for the various lesions, various views required for the surgeon. Often they don't show the lima, which is important for a surgeon. Earlier we used to be guided by the left ventricular end diastolic pressure, which are all totally gone. And the patient comments that they insist on having one stage. You have to decide, you have to prepare for whatever the findings, you have to put the stents in the same sitting, and that really reduces the option of the patients put on a bed for coronary angiogram. They have to decide instantaneously what they have to do. Then there are some aggressive interventions like left main, multiple vessel, diabetics, diffuse lesions. And when these patients come to the surgeons filled with multiple metallic stents covering all the coronaries, and we don't find any place where to put the graft. This is a very, very difficult situation. And sometimes I have noticed some people have said, a patient এসে বললো যে আমার PCI করতে মমিনুজ্জামান রাজি হন নাই কিন্তু অমুকে করে দিয়েছেন, উনি সাহস করে দিয়েছেন. So definitely when the topmost cardiologist denied a patient and the junior one dares to do that, that senior guy must have some logic. Heart team approach is very important, which is very little bit practiced in Bangladesh. It allows the cardiac surgeons and cardiologists exchange their views and obviously a better outcome and possibility of a hybrid procedure. So these two gentlemen were Werner Forsman, who actually performed the first catheter on himself, and Andreas Grundig, who did the first balloon angioplasty. So in conclusion, CABG offers survival benefit over the other modalities of treatment. In Bangladesh, CABG is cheaper than PCI. Economic consideration is a very important factor. There is no available statistics to support the notion, and the aggressive approach of some cardiologists may warrant caution. The heart team approach is not very common in Bangladesh and should be more in practice. Thank you all for your patient hearing.